Hi everybody, this is Dr. Rajkohila. Happy to meet you all for this INICET recall session. Analysis of the anatomy questions asked in this paper. Yes, to classify it as easy, moderate, difficult, okay, but it was somewhat a different paper and there were no questions from upper limb, lower limb embryology for the first time over the past few years. And most of the questions were from the thorax. Most of them were image-based questions. And neuroanatomy, there was 2 images for 1 question, isn't it? Okay, now we'll dive into the questions. So this recall, we'll be doing with the questions that I've got and the options. A 50-year-old male presented with lower lip weakness, asymmetric paralysis following parotidectomy. Injury to which of the following could have resulted in this condition? So, a case scenario describing lower lip asymmetry following parotidectomy. What are the 3 structures within the parotid gland from superficial to deep? It's the facial nerve, and deeper to that, retromandibular vein, and on more deeper plane, external carotid artery. The facial nerve, as soon as it exits out of the stylomastoid foramen, what is its first branch? The first branch is to the stylohyoid and the posterior belly of digastric muscle. The second branch is the posterior auricular branch of the facial nerve that goes to supply the occipital belly of occipitofrontalis and the auricularis posterior muscle. And then it's going to enter the parotid gland, okay, the posteromedial surface of the parotid gland. It's going to divide into 2 trunks, a superior trunk and inferior trunk. What are they called? The superior trunk is called the temporofacial trunk. And the inferior trunk is called the cervicofacial trunk. Now, yes, you can understand why I've gone to the discussion before reading of the options, right? Yes. The temporofacial trunk, it further divides into the temporal branch and the zygomatic branch. The temporal branch, it divides into supply the auricularis anterior, auricularis superior, the frontal belly of occipitofrontalis. And the zygomatic branch, right, that goes to supply the lower part of orbicularis oculi. The upper part is supplied by temporal branch. Now, this inferior division of the facial nerve, the cervicofacial trunk, that is the one which is going to divide into buccal branch, the marginal mandibular, and the cervical branch. The buccal branch, it typically lies below the parotid duct. It divides into superficial deep branches to supply the muscles of the upper lip, and the lower buccal or the deep buccal goes down to supply the buccinator muscle. Okay, the marginal mandibular branch is the one which typically supplies the muscles of lower lip. And the cervical branch is going to supply the platysma. So asymmetry of the lower lip, it typically indicates damage to which nerve? Marginal mandibular nerve. But that's not given in the option. So the best option to choose from the 4 will be cervical branch of the facial nerve. If the main trunk has gone, then it would have left in a lower motor neuron Bell's palsy. The temporal branch is gone, then it would have left to paralysis of the orbicularis oculi. Yeah, and the muscles of upper lip. Injury to the parotid duct is not going to result, but the lower buccal nerve is closer to it, right? So the best option will be cervical branch of facial nerve. And something to add on to it, so that will be useful for you. The marginal mandibular branch, okay, its course as you see here. It may not be along the lower border of the mandible. You can see it going down and then coming up to supply the muscles of the lower lip. So extreme care should be taken to not to injure this marginal mandibular nerve during a surgery over the submandibular salivary gland. So typically an incision for the submandibular salivary gland, the scalpel is when the knife is placed 2 to 3 centimeter below the lower border of the mandible. Okay, so the specific answer should be marginal mandibular branch coming from the cervicofacial trunk of the facial nerve. Coming to the next question, pointed structure which was supposed to be the ischial spine, right? the ischial spine, the level corresponds to, yes, it corresponds to, I'll just show you a picture. Where is the ischial spine here? This. This is the sacrospinous ligament and the sacrotuberous ligament. You see S1, S2, S3, S4, S5. So the tip of the ischial spine is well below the sacral vertebra. Okay, is well below the sacral vertebra, and it corresponds to something that's below the sacrum, that is the tip of the coccyx. The tip of the coccyx will be the best option, correct option for this question. And we have discussed a lot about the laryngeal nerves and their injury and thyroid, right? Which of the following steps in thyroid surgery is not likely to result in hoarseness of voice? So the division of the strap muscles, the tubercle of Zuckerkandl, and the Beer's triangle, all the three are related to which nerve? Recurrent laryngeal nerve. The superior thyroid artery is accompanied by the external laryngeal nerve. And what is the muscle supplied by external laryngeal nerve? Come on. It is the cricothyroid. What does this cricothyroid do? It tenses the vocal cord. Imagine a rubber band being pulled to its full length. Yes, stretching the vocal cord, tensing the vocal cord. Why do you want to tense the vocal cord? You want to shout, you want to increase the pitch of the voice, you tense the vocal cord. And that is done by this cricothyroid. So injury to the external laryngeal nerve while you try to ligate the superior thyroid artery lead to paralysis of the cricothyroid, and typically the patient is going to present with what voice change? A weak husky voice and not hoarseness. Hoarseness is typically for recurrent laryngeal nerve palsy. Okay, so this is the tubercle of the Zuckerkandl on the posterior aspect of the lateral lobe, and that is closely related to the recurrent laryngeal nerve. Again, the strap muscles that we need to divide. You can see the sternohyoid, nearby it, the superior belly of omohyoid, right? And this is the sternothyroid muscle. Sternothyroid inserting into the oblique line, and just above that is the thyrohyoid. Now, all these are going to be innervated from the ansa cervicalis, except the thyrohyoid that receives direct fibers from the C1 without forming the ansa, right? And Beer's triangle, it lies between the common carotid artery, the inferior thyroid artery that comes from the subclavian artery, and the recurrent laryngeal nerve. Okay, again, it is related to recurrent laryngeal nerve. Okay. Joel's triangle, it is bounded by the midline, by the superior thyroid vessels, and the superior pole of the lateral lobe. Yeah, and in the floor, we have the inferior constrictor muscle arising from the cricoid cartilage. And we know the external laryngeal nerve is related to it. Okay, trying the Joel's triangle. And yes, just a quick discussion of these three nerves. Internal laryngeal nerve is entirely sensory. It supplies the mucosa of the larynx. Yes, above the vocal cord, right? Above the vocal cord. And recurrent laryngeal nerve is sensory and motor. Sensory to the mucosa of the larynx below the vocal cord, and motor to all the muscles of larynx except cricothyroid. We have seen about external laryngeal nerve. So what will happen when there's injury to internal laryngeal nerve, especially where it is traversing the piriform fossa, it can be injured by a foreign body lodging there. That will lead to, yes, aspiration. The sensation from the mucosa of the larynx is not carried, right? Okay, so any food particle that enters, irritates, you are not able to cough it out, it goes for aspiration. So here again, aspiration, recurrent laryngeal nerve, and hoarseness, because most of the muscles supplied by this recurrent laryngeal nerve. And one more symptom in recurrent laryngeal nerve palsy, dyspnea. Why do we get stridor, dyspnea, and recurrent laryngeal nerve palsy? Because this recurrent laryngeal nerve supplies the posterior cricoarytenoid, which is called as the safety muscle of larynx. It is the only abductor of larynx. It keeps the vocal cords away from the midline. So paralysis of this posterior cricoarytenoid, the vocal cords are not able to move away. They remain closer in the cadaveric position, paramedian position, causing difficulty in airway, right? So yes, the best option is going to be here. Ligation of the superior thyroid vessels will injure the external laryngeal nerve, leading to weak husky voice. Coming to the next question, easy one. Which of the following is true regarding which is true? So, the breast tissue, like the parenchyma, there are around 15 to 20 lobes, and each lobe there are like more number of lobules, okay? And the nipple, location of the nipple, the first line, it's variable, right? It's variable with gender, with age. But most of the people over the fourth intercostal space, but general variable. And the suprolateral quadrant has more amount of parenchymal tissue than the supromedial quadrant. And from the outer part of the breast quadrant, you can see the axillary tail of Spence. It goes along the inferior. This is the pectoralis major. The anterior axillary fold is contributed by the pectoralis major. So this, the axillary tail of Spence, it goes along the infralateral border of the pectoralis major. Sometimes it can pass through an opening in the axilla, the foramen flanger, okay, and it is in contact with the anterior group, the pectoral group of lymph nodes. So yes, this could be the best option of the four. And this was a direct question. Most common hernia in the females. Yes. Nucleus for the structure related to the marked area lies in. So there was a lot of controversy whether it was a cadaveric specimen of the lung of the right side or the left side, and whether the structure was marked anterior to the hilum or posterior to the hilum. Okay, so this is your right lung. This is the left lung, isn't it? And I was told that it was given, the marking was bit over the arched part of the hilum here. Now we know hilum, anterior to the hilum, it is the phrenic nerve undoubtedly. And posterior to the hilum, it is the vagus nerve undoubtedly. Okay. And from the options, whether it's right or left, doesn't matter. Anterior, it is the phrenic nerve, and posterior, it is the vagus. Of the options given, okay, the root value for phrenic nerve, it is C3, C4, C5. Okay, and the nucleus for the phrenic nerve is situated in the anterior gray horn. Okay, anterior gray horn. The phrenic nerve nucleus is situated in the anterior gray horn of the cervical segment of the spinal cord, C3, C4, C5 region. Okay. So if it was posterior to the hilum and if it was vagus, then we can tell the nucleus of the vagus, okay, the dorsal nucleus of vagus, the nucleus ambiguous, all the nuclei related to the vagus, they are situated in the medulla. Okay, but I think it was phrenic nerve, and then this would be the apt answer. And again, another easy question. Chest X-ray PA view, like it was told that the arrow was on this part exactly. And what you see here, this is the midline posterior view. We can see the rib getting closer to the midline, then it means it's the posterior end, right? And if you trace the rib, the anterior end, it goes more obliquely. And this area where there is no like any bony thing, it's going to be the costal cartilage. So this would be the ideal site. If the arrow is there, then it is the posterior end of the rib. Anterior end, they would have chosen a better place to mark it, and costal cartilage is not going to be seen there, right? And the vascular markings, yeah. So the apt answer should be the posterior end of the rib. Again, yeah, a question on the blood supply of the heart, yes, but what was the exact marking? So as you see here, is this the image given? Okay, you can see this is the interventricular septum. You know, the interventricular septum in the uppermost part, posterior part, it has a membranous component. Okay, and this membranous component, the uppermost part of it separates the right atrium from the left ventricle. It's called the atrioventricular septum, and that transmits the left bundle branch to the left ventricle. And here, this is the interventricular septum. It's an anterior view, so we can take it as an anterior interventricular septum. And here, there is one anterior papillary muscle in the right ventricle. From the interventricular septum, you can see a septomarginal trabeculae going towards the base of the anterior papillary muscle, and that will transmit the right bundle branch. So what exactly was marked? You know that the anterior interventricular artery, which runs over the anterior interventricular groove, it supplies the antero-superior two-thirds of the interventricular septum, the left anterior descending or the anterior interventricular artery. Okay. The posterior part is the posterior interventricular artery, branch of right coronary. I think that was not given here. And the left bundle branch traversing the membranous part of the interventricular septum is usually supplied by the left carotid artery. Okay. Rarely, in a few percentage, by the right coronary artery. Whereas the right bundle branch is exclusively supplied by the left, carotid artery. Right? Okay. Now, if it was the anterior portion of the interventricular septum, then the best answer is going to be anterior interventricular artery. Right? Again, this was another interesting question. Cross section at which level was it? I've tried to compare the different cross sections. There was also controversy in the image put. Just we can learn it. Okay. So this I'll put it and then explain. This is T9. This is T10. This is T12. T12 and L1. Is that visible there? Okay. Now just compare these four sections A, B, C, and D. Okay. You can see a difference in the curvature of the body wall as we go down. Right. Then where is the lung here? Yeah, you can see the anterior posterior, right? I've put the markings over the vertebra. So this is the right lung. This is the left lung. As you see, the lung, as we go down in sections A, B, C, D, the lung you can see up to T10. The lower border of the lung corresponds to 6, 8, 10. Remember, the lower border of the pleura will correspond to 8, 10, 12. So the lungs can be seen up to T10 and the pleural cavity can be seen up to T12. Right? Okay. Or you can make out the liver and IVC. So this is the liver. This is the inferior vena cava, right? Can you see the right lobe of the liver is seen well in sections A, B, and C and D starts, as we go down, it starts decreasing, right? Okay, yeah. And the inferior vena cava, here, can you make it out? In T9 level, T10 level, and here in T12, this is the IVC, you can see the hepatic veins opening into it. In L1 level, where do you get to see the IVC? This, I'm sorry, the portal, here. This is the, here. This is the inferior vena cava in L1 level. So you can see it has just completely come outside the liver as we go down, right? The liver and the inferior vena cava. Higher up, it is within the liver, then lower down, you can see it separating from it. And then coming to the aorta. Where is the aorta here? Exactly, in front of the vertebra, right? Here, this is the aorta T12 and L1. Can you see the aorta here and one branch coming from the aorta? What could this be at L1 level? Superior mesenteric artery, right? Superior mesenteric artery, right? At L1. And then interesting is esophagus. Can you appreciate where is the esophagus in T9? Here. This is the esophagus, right? In the midline. What do you see at T10 level? The esophagus opening into the stomach. This is the stomach, right? The esophagus opening into the stomach. And in T12 or L1, you don't see esophagus as such. The other parts of the intestine, they start appearing, right? And interestingly, like the spleen is seen over here. This is the spleen, this is spleen, the spleen becoming well defined here. The kidneys, can you appreciate the kidneys here? This is the kidney, the left kidney, the right and the left kidney. Okay, so the kidneys, they start appearing in the T12. And what is the first one to appear? The left kidney, right? And in L1, you can see both the right and the left kidney. Okay, so a comparative discussion of all these sections, we can conclude that if this was the image given, then it is going to be T9. Why not T10? Because in T10, you can see the cardioesophageal junction, right? And why not T12 or L1? You don't get to see the esophagus in those sections. Okay, so what are the things that is clearly visible here? You can see this is the, the anterior aspect. I'll take a different color. The anterior aspect, the posterior aspect. Is it visible here? Yeah, I'll take a blue color. T9, this is the anterior aspect. You can make out the lung, right? The right lung, the left lung. You can make out the liver on the right. You can make out the inferior vena cava, the beginning of the hepatic veins approaching it. And this is the spleen. You can make out the stomach, the fundus of the stomach probably. This is the aorta, the esophagus, the acygos vein, and even part of the heart, the inferior border of the heart contributed by the right ventricle, that is seen here. So if this is the section given, then we can substantiate solidly that it is the T9. Okay, T10 cardioesophageal junction, T12 L1 no esophagus. The other parts of the intestine begin to appear. Is that fine? Okay. Then this structure passing to the pointed area. This was a like easy. I think it is an easy question. You should have got it right. Okay. So this was the pointed area between the superior constrictor, middle constrictor, and the inferior constrictor, right? So what passes below the inferior constrictor? Recurrent laryngeal nerve, inferior laryngeal vessels. What passes between the middle constrictor and inferior constrictor? Yes. Yeah, the middle constrictor, it's coming from the hyoid, the inferior constrictor from thyroid. So thyrohyoid membrane is the piercing that will be the superior laryngeal vessels and the internal laryngeal nerve, right? Between superior constrictor and middle constrictor, it is the ninth nerve and the muscle supplied by it, stylopharyngeus. Now, what passes above the superior constrictor? What is that area called? Sinus of Morgagni. Sinus of Morgagni, what are the structures passing through? Yes, the muscle, levator veli palatine muscle, the auditory tube, the ascending palatine artery, palatine branch of ascending pharyngeal artery, right? Through sinus of Morgagni. So, yes, hope you all got it right. Yeah, that was a direct question. Then this was another controversial question. The two images given, what was it? Yeah, I put few humpty number of images. You can help me with this. So what is this? You can see the cerebral aqueduct. You see the dark, big pigmented band of gray matter, the substantia nigra, the red nucleus. So what was actually asked, substantia nigra or the red nucleus in image 1? Right? And this was a coronal section, image 2. So here, I don't know where the markings were put. I can help you with all the gray matter. This is the caudate nucleus. This is the thalamus, the lentiform nucleus putamen, globus pallidus. This is the subthalamic nucleus. Below is the substantia nigra. So these show you the components of the basal ganglia. right? But there was one confusion in what the messages, the text messages that I got. Someone are talking about the dentate nucleus. I don't know whether you got to see any crumbled back appearance, any wavy thing. This is the dentate nucleus of cerebellum. And this is here. Another person was talking about the olivary nucleus of medulla. So, what was that you actually got? Okay. So, substantia nigra, talking about what is it connected with? The basal ganglia, what are the components of the basal ganglia? It consists of the corpus striatum. It also includes the subthalamic nucleus, the substantia nigra, the claustrum, the amygdala. The corpus striatum, it consists of the caudate nucleus and the lentiform nucleus. Lentiform nucleus is further divided into putamen and globus pallidus. This caudate nucleus and the putamen, they share a common function. Together, it is called as the striatum, whereas this is called as the pallidum. Now, all the inputs to the basal ganglia, which is concerned with coordination of the movements, right, is brought to this is the input. It receives all the input. Okay. And this pallidum, that is the efferent component. Okay. The substantia nigra, if it is going to project to the basal ganglia, it has to project either to the, yes, caudate nucleus or to the putamen. Right? Okay. So the major efferent from the globus pallidus is going towards the thalamus as the thalamic fasciculus. So which one was marked? Whether caudate nucleus or putamen? Okay. Talking about the red nucleus. The red nucleus, okay, and it could be connected with the dentate. The main output of the dentate nucleus is going to the thalamus and the red nucleus as the dentato-rubro-thalamic tract or the dentato-thalamic fibers. Okay, and the main projection of the olivary nucleus will be into the cerebellum, the olivocerebellar fibers, the mossy fibers that enters the cerebellum through the inferior cerebellar peduncle. So I probably think it was the substantia nigra of the midbrain, which projects to the striatum shown in the coronal image, whether which one was marked, whether the putamen or the caudate nucleus. Okay, you can give me the input. Right. This was again another interesting question. Which of the following joint type is not found in relation to the bone shown? So this is a vertebra and yes. So here I've shown you the costal facets with the thoracic vertebra. You know, the body of the adjacent vertebrae are connected at the intervertebral disc, right? By, what joint is that? The secondary cartilaginous joint or the symphysis. Okay. And then the articulation of the adjacent vertebra with the articular facets, that is going to be plain synovial. And Gray's anatomy, it gives that this connection between the adjacent vertebra by ligaments, the spinous process of adjacent vertebra getting connected by ligaments, right? Okay. The interspinous, the supraspinous ligament, all that as syndesmosis. It is given in Gray's in the chapter of back, okay, where they discuss about the vertebra. The joints between the vertebra, it includes the symphysis, the plain synovial, and which is syndesmosis. Okay, if you want to talk about the ribs, okay, the ribs are part of the costal elements of the thoracic vertebra, and the junction between the rib with its costal cartilage is primary synchondrosis, similar to the first chondrosternal joint. So I prefer to go with not found. Okay. A structure that's not present in the floor of the inferior horn of the lateral ventricle. Okay, a few details about the lateral ventricle. You know, the lateral ventricle is a C-shaped cavity. Yes, with the extension into the frontal lobe as anterior horn, into the occipital lobe as posterior horn, and into the temporal lobe as inferior horn. Right. Okay, so this is the medial surface of the brain. This is the corpus callosum, the rostrum, the genu, the body or the trunk, and the splenium. What you see here in this cavity, I'll take a highlighter, okay? This cavity that you see here is the lateral ventricle. And in the floor of the lateral ventricle, this is the caudate nucleus. This is the thalamus. This is the fornix. Okay? Yeah. So the anterior horn, okay, the anterior horn is the extension into the frontal lobe. It will be bounded, the roof, the anterior wall, and the floor is going to be bounded by the corpus callosum. And in the floor, we'll have the head of the caudate nucleus. The caudate nucleus is again a comma-shaped structure. Okay, it has a head, a body, and the tail. That will again follow the curvature of your ventricle. Okay, the anterior horn, the inferior horn, and the posterior horn. Right. Now coming to the like the boundaries of the central part of the lateral ventricle, it is bounded above by the corpus callosum and below by the caudate nucleus and the thalamus and the fornix, the thalamostriate vein, the stria terminalis, all that. This is the posterior horn, the posterior horn of the lateral ventricle. So the posterior horn, the roof, the lateral wall, the floor will be formed by the fibers that come from the corpus callosum, the tapetum, right? Whereas the medial wall, you get to see two bulge. The first, this is the corpus callosum, the fibers of the corpus callosum going towards the occipital lobe. It's called as the forceps major. So the upper bulge on the medial wall is the forceps major, it's nothing but the fibers of the splenium going towards the occipital lobe. And the lower bulge is produced by the indentation of the calcarine sulcus. It's called calcar avus. Now, as I told you, so this is the cavity of the lateral ventricle. You can see the posterior horn and inferior horn. Where these two horns diverge, that's called the collateral trigone. The inferior horn is the largest, okay? It's the main continuation of the ventricular cavity into the temporal lobe. You can see the caudate nucleus, the head, the body, and the tail. So the head, the body, they form the floor for the anterior horn for the central part of the lateral ventricle. But the tail, as it comes here to the inferior horn, it's going to contribute to the roof and not the floor. So what are the other things that lies in the roof and the floor of the inferior horn? In the roof, okay, we'll get to see the tapetum fibers again laterally. Medially, the tail of the caudate nucleus in contact with the amygdala. The efferent fibers of the amygdala going towards the hypothalamus is called stria terminalis. So these will be present in the roof of the inferior horn. In the floor, again, we'll get to see two bulges there. The one laterally is produced by the collateral sulcus on the inferior surface of the cerebral hemisphere. It's called the collateral eminence. And more medially, we'll have the hippocampus. And the white matter over the surface of the hippocampus, the alveus, the fimbria. Okay, so the tail of the caudate nucleus is related to the roof of the inferior horn and not the floor. Yeah. And two questions from histology, but not a direct question, right? Asking for identification and all, but yeah. Identify the zone of calcification. Which one is it? Okay. So this is, what is this? This is epiphyseal cartilage, the growth zones in the epiphyseal cartilage. So what you see as A here is just the reserve cells. There is no proliferation, there's no active matrix formation. Okay. And then zone B, it is just proliferation, the zone of proliferation where the cells proliferate, they arrange like a coin stack appearance. And C, where you see the nucleated cells quite appearing bigger, that is the zone of hypertrophy. What happens next is interesting. These hypertrophied cells, what will happen? They will lyse. They will lose their nucleus. They start to disintegrate. And that is the area where the calcification begins in the matrix, zone D. What happens here is next to it. What will happen? New blood vessels will enter, new matrix formation. And these new blood vessels that enter, right, that will bring the osteoprogenitor cells for bone formation. Okay, so zone of reserve cartilage, zone of proliferation, hypertrophy, and then calcification where the cells lies and the matrix is calcified. And then the zone of ossification, bone formation. Okay, so yeah, resting cartilage, the coin stack appearance in proliferation. You can see the nucleated cells in hypertrophy large. The cells lose the nuclei in the calcification zone. Yeah, again, this was from the sub questions, it would have given a clue for you what it is, right? The histology of adrenal gland. So we have the adrenal cortex that develops from the intermediate mesoderm, the adrenal medulla that develops from the neural crest. G, F, and R. R is smaller, right? Okay. Zona glomerulosa, fasciculata, and reticularis. You know, the glomerulosa is the one which is going to secrete the glucocorticoids, aldosterone, that plays an important role in electrolyte balance. I'm sure you must have got it right. Okay, the last question. The second order neurons present in the spinal nucleus of trigeminal nerve carries with which of the following sensation? Easy, right? This was also direct. You should have got it right. So the trigeminal nerve, what do you know about it? It is the largest of all the cranial nerve, isn't it? Okay. What are the nucleus of the trigeminal nerve? One motor nuclei and three sensory nucleus. One is the spinal nucleus of the trigeminal nerve, and second will be the chief sensory nucleus of the trigeminal nerve, and lastly, mesencephalic nucleus of the trigeminal nerve. The motor nucleus of trigeminal nerve is seen in pons along with the chief sensory nucleus. Spinal nucleus mainly in the medulla and mesencephalic nucleus mainly in the midbrain. So the spinal nucleus is all related to yeah, motor, you know, the muscles of mastication, the tensa tympani, tensa belli palatini, anterior belly of digastric, and mylohyoid, 8 muscles. Nerve of the first pharyngeal arch, right? Mandibular division of trigeminal nerve. Spinal nucleus, it receives pain and temperature sensation from the face. The chief sensory nucleus that receives the touch and pressure, right? Mesencephalic nucleus receives the proprioception. It has the first order neurons in that pathway and unipolar neurons. Okay, yeah, proprioception from the face, right? Yes. So, of course, an easy question. Spinal nucleus receives the pain and temperature from the face, right? So coming back to the analysis again, it was accepting it is a different set of questions this year, which was not over the last few years, few questions. But I'm sure the concepts, if you have understood, you would have been able to answer because everything was sort of a high yield topic only. Most of them were image-based questions. But as again, if the concepts have been understood, definitely you would have able to get it near right everything. Okay. Hope this session was useful. Thank you.